Live now, sir.
Okay. Hi, good evening, dear viewers. Thank you once again for the third consecutive week that you're joining us for the pre-conference workshop for the International Spine and Spinal Injuries Conference. This conference is unique. It's the 25th year, and at the same time, it's a combined meeting of the Spinal Cord Society of India, AO Spine Knowledge Forum for Trauma, and the Asian Spinal Network. This is being organized by Kaveri Hospital and Hamsa Rehab from Chennai. This year, we have got a huge variety of programs, both academic as well as cultural, to show you a taste of South India. So it's happening at the Hyatt Regency in Chennai. It's for 3 days, 31st of October, Friday, November 1st, Saturday, and Sunday. The first 2 days will be the conference, and the last day, the November 2nd, Sunday, is an workshop. Welcome to Chennai, and here we are going to connect you with tradition and innovation and make it as interesting as possible for you to be here. So, we are expecting around 400 spine neuron ortho experts. We are expecting about 300 rehab specialists, which will be rehab doctors, physiotherapists, occupational therapists, researchers, and scientists. And we have various programs connecting consumers, which are the patients, the researchers, scientists from IIT, and various other things. So, we're going to look a deep dive into spinal cord injury rehab. The theme of the conference is the new era care of spinal cord injury. There's going to be very interesting things happening. Not to mention, we have a whole variety of speakers, all the leaders and the stalwarts of spine surgery in the country. And we have a lot of them who are actually not listed here, but we have almost about 120 faculty, which are including both spine surgeons and rehab specialists. We also have Dr. Alex Vaccaro coming in person, and he would be giving the keynote speak. And also, he runs in a few debates and other programs. We have about nearly 35 to 40 AO spine faculty from the Knowledge Forum and also from various other parts of the world for the rehab program as well, because it's a combined Asian Spinal Cord Network meeting. So we have people from Thailand, Malaysia, Seoul, Bangladesh, and various other Asia Pacific countries as well. On the last day, we have the spine boot camp for trauma. So the boot camp, which you all are aware of, is an hands-on practical workshop. But here the theme is going to be fully focused on trauma-related workshops, which includes showing in a lot of technology, hands-on skills on pedicle screw fixations, fracture reductions, and also at the same time, we are going to look into, baclofen pumps, spinal cord stimulators, robotics in rehab, exoskeletals in rehab, and various other things which are also used for rehabilitation. So there'll be a mix of various things, and there'll be an hands-on experience for you as well. So we've had some very good speakers on pediatric spine trauma. We had on Asia A neurology, and we also are going to have for the next 3 weeks speakers from Canada, from South Africa, and from the US who are going to share a lot of experience. But today, I'm going to welcome our special guest, Dr. Abhay Nene, who doesn't need introduction to the Indian spine community, but we also have some speakers from international. So it's an internationally well-renowned a spine and orthopedic surgeon from Mumbai. He's an amazing person, an excellent surgeon, a lot of experience in pediatric adult work and trauma, of course. And he's also a man, as you can see, as you will see him in a minute, who's not just a doctor, a surgeon, but he has a variety of interests, including trekking and music. Without any further, I would like to invite Dr. Abhay Nene, please, to talk about the today's topic.
Wow, thank you so much, Dr. Bala. This conference seems like it's going to be the hottest thing for this year, I think, because I think the array of physicians that you've lined up it's going to be really unbeatable. I don't think even our national conference has this kind of an array. So I'm proud of the way you're conducting things, and it's going to be one hell of a meeting. And I'm excited to be in this pack because I'm in the, my name is now associated with the who's who've been on this webinar. So thank you for having me here, and it's a great privilege. We are going to discuss osteoporotic fractures today because that's one of the more common fractures that we see in cold orthopedic practice or cold spine practice. And I'm going to open up with this. And of course, we have a good elite faculty that's sitting here with us on the Zoom panel, and we may get their inputs also. So, what do you think about this case? Bala, maybe what do you think?
Yeah.
This lady, typically in Bombay, if they don't get better, they keep doing MRI scans, and this is how this went.
Yeah.
This was many,
So
many years ago. As you can see, it's dated, I think, 2012. And she just went bad in front of her eyes. At that time, we only had osteophos or whatever. We didn't have any teriparatide, etc.
absolutely. So this is a very, very common scenario. What you're showing here is a compression fracture, which normally does heal conservatively if managed. And sometimes, as you said, people don't follow up and they just put them on some calcium tablets. And sometimes even don't get a DEXA scan and then just leave them and tell them it's going to heal, take bed rest. So what bed
What is
rest?
your typical trick to treat them? Like when a fresh fracture like this comes in, you ask them to take bed rest, you do bracing. What do you do? Vertebroplasty?
Yeah, so I normally give them first couple of weeks, or at least for the first 4 weeks, I give them conservative management, bed rest, meaning they can only walk up to the toilet and bed rest most of the times. I give them a belt if they when they walk to the toilet, and typically this would be a TLSO kind of a brace, not just a lumbar brace. And then I would most importantly do a DEXA scan, and at the same time start them straight away on some teriparatide injection,
Anabolic kind of therapy.
anabolic things, and follow them up very closely. So I would tell them that either if your pain gets more, or if you develop any neurology, which I will educate the family, and usually the elderly patients, so the family needs education, and see them every 2 weeks or 4 weeks and do x-rays to start with. If their symptoms are kind of getting better, the pain is subsiding, and I'll just keep following up for up to 3 months and not do any further treatment,
I think
accepting
the
a little bit
message
of
here
follow-up.
is quite loud that if whatever the DEXA scan score shows, this is obviously severe osteoporosis. If it's an insufficiency fracture, and you got to put them on anabolics typically, isn't it?
Yes.
Like you don't mess around with the lower drugs. Dr. Soma, how often do you see this happening? Like most of them heal, isn't it? Like in your practice, how often do you see them degenerating like this into a cord compression within?
Yes, sir. Yeah, definitely. Being an elderly female with a trivial fall, obviously we'll first go for an osteoporotic fracture, and initially the fracture, the height of the vertebrae looks much stable. There is a slight posterior wall component. Just look into the posterior ligament just to be on the safer side. However, our treatment protocol, as sir has said, we just go ahead with conservative. Try to give them rest. Try to get their pain down. Probably start them on take a DEXA, start them on anabolics as early as possible. Give them supplements, and if the pain is high, we'll start them on calcitonin simultaneously. And go ahead, have a watchful follow up. Advise the patient not to go for like another fall, and uh, that is it. I think that is what.
I think you've summed it up very well. So I think the fate of an insufficiency fracture typically is one of healing. It just compresses, consolidates. But there's one entity that's not often discussed, and that is non-union. So most fractures will heal, but remember they heal with collapse and a little bit of kyphosis, and that does leave these guys with discogenic injury. I mean discogenic pain, like a 20% weak back as we call it. But they heal, so they normally don't have a problem, but you'll all see this kind of a scenario once in a way, and approximately 2 in 10 would have this, where the fracture is refusing to heal and you have this alligator jaw opening, with empty space in the middle, and these guys are very, very, very unhappy because they come in with a lot of pain. And long ago, we in the European Spine Journal, we published the likely features on day one that could predict that this fracture is going to not unite. And I think the key takeaways were end plate fractures because there's no union with the disc. If the anterior cortex is broken and if there's an old adjacent osteoporotic vertebral fracture, these are all red flags that you may watch for non-union in these cases. And no matter what, once this non-union happens, initially we really didn't know what it was, but the Japanese actually biopsied this, etc., and they identified this as an avascular necrosis. So the ones that go into non-union actually have a pseudo arthrosis that forms there with synovial cleft and a cavity. And when this elderly man comes in, you almost feel he's maligning because he walks the entire length of your corridor without pain. But the minute you want to put him in bed, he's like howling, and getting out of bed is impossible for him. So transitional movements are the ones that cause pain, and this is what we call clinical instability, which is extremely disabling for these guys, and their entire lives, activities get completely on a on a ransom almost, and they're just stuck and they don't know what to do. So even though they look okay when they're standing, the neurology is fine when they're lying down, they can be very, very disabled. So really, the surgeon comes in when there's a when there's a instability that comes in. If the patient heals, I think it's the physician who deals with the osteoporosis medically. But here is where we come in, and these are the strategies that are available at our disposal, as you most of us would agree. So vertebroplasty has been the age-old first strategy. It came in with a lot of goodwill, a lot of good potential for filling up this defect that is not healing. Albeit it's with cement, so you're filling it up with a material that does not necessarily match with the with the weight bearing capacity of the soft bone. It's an outpatient procedure, potentially under local anesthesia, so it became quite popular. And I think all of us, I don't know, Bala, how you must have done tons of these, right, in the beginning of the century. We've all
Yeah, definitely. I mean, when we trained in the UK, I would have patients come in on stages and have at least 7, 8 levels done.
And
Yeah,
how were your
common
results? Like,
abroad.
how did
Yeah.
you like the immediate results?
You see, the immediate results on most of these patients was they had good relief. Yeah.
Fantastic relief, isn't it? Magic.
Fantastic.
They would
Yeah,
like
yeah. They
dance
are
out of
very
their
happy patients. But then when you keep seeing them again with more and more and more fractures, then the question of you cement the fracture which has fracture and then put some cement in the adjacent, then you get the one above that as well.
Absolutely. I think you nailed it. I think all of us were very excited when this came in, and we were, pumping cement into all these. And then we realized that initially they are very happy, but as they keep coming back to you, they are increasingly unhappy for the obvious reasons. And the obvious reasons is that the osteoporosis is untreated. The reason why they had the fracture is not treated. And back then we were not so bullish about teriparatide nor, the romosozumab. So we were kind of just treating them with alendronate, and obviously it was a formula for failure. And the longer they, followed up, the worse they would be. And now that you put in cement, it was your baby. So again, with our group Vishal and the gang, we published this post-vertebroplasty instability, where if you extend the follow-up of your V-plasties, you might find that they really don't do as well as we sell the procedure. Like look at this case of a T12 non-union. We normally would wait at least a couple of months before offering vertebroplasty. And you may say that it's a fair case to do vertebroplasty, but if you see from the paper in European Spine Journal, the anterior cortex is not completely intact. And even when you pack in this cement, you see the cement is like lining up well. It's not diffusing into the body. So the cement is sitting there like a strong piece, but the bone around it is like an eggshell. So soon it's going to crumble because you've not done anything about the bone strength. So this eggshell crackling can happen in like half a year after the vertebroplasty. So after an initial good result, they come with a dramatic failure because this is a disc vertebral instability. It's no longer a intra-vertebral or intraosseous instability, and this can lead to even neurology. A lot of these, like this patient came with buckling of of her legs when she stood up. She was all okay when she laid down, and this then needs a full operation. So now you've created a monster by putting in the cement. So kind of the bottom line is that you want to aggressively treat the osteoporosis and not take this upon yourself. Doing the V-plasty. So the question is then, when would you consider instrumenting in an osteoporotic vertebral fracture, which means that which are those cases which will fail a V-plasty alone? And that's the data we got out from that one paper in the Journal of Neurosurgery Spine. So if a fracture has any of these, these features, if there's, of course, neural canal encroachment, if it's a non-contained fracture, if the fracture is close to the end plates, focally if there's kyphosis instability or pre-existing adjacent pathology, and generally if it's a very severe osteoporosis untreated or a high demand back. Let's just dive into a few of these. So if there's neural canal encroachment, so when you look at the x-ray, sometimes you don't see anything. The patient does not necessarily have neurology in lying down, and the tip here is to get them vertical and then assess their neurology. But you have this on the MRI, which means that before any vertebroplasty, you got to do an MRI scan. You don't do a V-plasty without an MR. Because in this case, if you push in cement, there's a high chance that the posterior fragment may push back and you may create a neurology. And that's not a good place to be because the patient is often under local anesthesia, suddenly may develop, something. So you got to be worried. And also, if there is clear neurology on clinical examination, you don't want to do a vertebroplasty. The other is a non-contained fracture. Once again, on an X-ray, you often feel that your fracture is contained, but you do a CD scan, and the whole on the axial image it looks broken down. Dr. Soma, how often would you do a CT scan in a osteoporotic vertebral fracture? Like, what would your indication be to do a CT scan, like ahead of an MRI scan?
Yes, sir. Whenever there is we feel that the fracture line is slightly extending, whenever there's a cleft, whenever the bone quality in the MRI, what we are seeing is something not correlating. The patient is having an exaggerated symptoms, which is not correlating with the MRI. Just better to go ahead with the CT scan to see the exact fracture. And but to tell you the truth, not every vertebroplasty what we plan, we go ahead with the CT. Because we try to get more understanding with the MRI and the X-rays alone.
Correct. So this has always been the issue, because CT is like, once you do an MR, you feel you're done, but very often on a CT you find that it's not as pretty as it looks. The box should be intact to fill the box, otherwise it's going to spill over. So maybe it's a controversial indication, but maybe if you want to do any intervention, you want to do a CT and an MRI scan. And then, of course, the fracture is close to the end plate. Like, again, this looks innocuous on the MRI, but on the CT, you see it's like opening up into the disc. And here, if you put in cement, the cement is going to leak out pronto. And if it leaks into the disc, it causes avascular necrosis of the disc. And that is not going to heal. And you end up from an intervertebral or an intravertebral instability, bone instability, osseous instability, to a disc vertebral instability, which is never going to heal. So you're created a problem. Also, kyphosis, like you'll see some elderly who are already kyphosed, their center of gravity is way ahead, and they develop a fracture. It's too much to expect a V-plasty cement ball to actually hold up this kyphosis. If the instability is severe, for example, in this was a gynac, the senior gynecology, she slipped and fell, and she was really in pain. She was brought on a stretcher. And again, this looks innocuous, but in reality, you will see translation there. So it's no longer just a compression fracture, though she fits the bill of an old lady with a compression fracture with multiple wedge vertebrae, severe osteoporosis, actually a 3-column injury. And there's no way that you're going to do a V-plasty. Again, you're creating a monster. You're actually giving, the column a fulcrum to move on. So you want to be watchful there. And of course, in case of multiple fractures like this, you're just doing too little too late by doing a vertebroplasty. And then if the osteoporosis is very severe, they may actually need a V-plasty, but you may want to cover your own ass by not doing a V-plasty and just putting them in bed and giving them medication. You don't want to make their problem into your problem. And in these cases, I don't know, Dr. Bala, how you think, but I normally, it's very hard to, because they are like quite disabled, but their osteoporosis is so severe, like -7 and stuff. So you want to just tell them that this is a bad scenario, and instead of looking for magic, just lay low and take your teriparatide, Evenity, whatever you need to, and let's see, keep reassessing. How do you handle these? Because more and more of these are coming to you, isn't it now?
Yeah, no, no, very true. I mean, these are something that we are seeing from time to time, not very frequent, the -4 plus kind of. In these, I think, as you said, first thing is never touch them with instrumentation alone. And however bad it is, unless they have neurological deficits that's impending, and you have to do something where you have to have a lot of strategies, and giving them a proper consent and creating the awareness, because implants will fail in these. And again, injecting cement. When I was working in Germany, one of the things that they used to do for this is they do something called as an lordoplasty. So they basically put cement and put an Gemshidi in the levels above, try to create correct the kyphosis a little bit, and then put cements in the level involved and the adjacent levels. But even that, this is very soft bone, and it is just going to crumple. So I think in the very extreme osteoporosis, bed rest and 6 months of anabolics and biologics, and then after that, consider it. So they are not easy decisions, and I think communication with the family is the most key, I think, here.
Cut down expectations. This is a bad disease, and it's gone on too long. If you put your hands in fire, you're going to burn them. So you got to be watchful. I think that's a good message. Coming from everyone. So here's a special situation which we see in our kind of a setup. This guy's a farmer, so he's doing heavy loading stuff. He's 70, but he's still like doing everything. and he is a good candidate for a V-plasty as per radiology, contained fracture, etc., etc., and gets a great result, goes back to farming and comes back like this. Because now he's got a cement in a pile of, or like a stone in a pile of cushion. His cushions have still not strengthened, and this stone is now rubbing. And this is a different scenario. There's no eggshell crackling. There's an adjacent segment end plate getting rubbed off on this stone that is chiseling it away because of the overloading, because of the modulus of elasticity that is so different between his original bones and his muscle. And remember, there's significant sarcopenia in these people. So there's no muscle that's holding him up. It's all, the whole weight bearing axis is along his vertebral column. So it's a pretty complex biomechanical situation to deal with. And maybe bracing here, Dr. Soma, maybe bracing here after, what do you think? I mean, I am normally very aggressive and no brace, but I think in this guy, a brace would have probably kept him down. Would you?
Probably, sir. But many of the studies have come up with towards non-bracing, and very few have supporting bracing these days. And however, the frequency of the brace they use once they get up and go, that also matters. However, like there are many studies which have come up with like assessing the osteoporosis and starting them on anabolics as early as possible, even probably sometimes even before the procedure also. Would play a role, especially in these severe fractures like more than less than -4, -5. Always, whenever we are increasing the stability or the strength of the construct at one level, the other level is always at risk because of differential strength.
And that
And
calcium sulfate cement, which has got lesser modulus of elasticity, that was being sold as a better item, but it never really took off, isn't it? Have you read anything about it? Because it never came up, and we're still stuck with PMMA.
yes, sir. Yeah. So that I think the clinical studies, not sure how significant those are and how fast effective they are, because in this PMMA we can see the effect very immediately. Right. The patient will walk out of the table very happy, and that is one of the procedures which give you a good satisfaction as a spine surgeon. But other I'm not aware of, sir. The calcium phosphates, the calcium sulfate, which you have.
So then what's the role of surgery? Let's just move to that. So in the past, it was unheard of to do surgery in Australia. And I remember that in one of my visitations in North America, I said that I'll take a talk on surgery in osteoporotic fracture. And they said, really? Like, does this even happen? And this was like not too long ago, like I'm saying 15 years ago. And now the whole world is kind of focused their attention because these guys come in, fast and thick. And older people are living longer and living more healthy lives. And we are just trying to figure out what the algorithm for surgery would be. Once again, we published this in the European Spine Journal way back in 2011, like almost like an algorithm. So I'll use this data to take you through the options of surgery, which seem to be logical. We have not been able to validate this because after that it's been just gung ho, just come and follow this algorithm. Maybe it's time for us to go back and relook at this. But the algorithm is quite simple. If you have a non-union with no neurology but radiological cord compression, which means that you've established that this is not healing. You've established that there is radiological compression when you do the MRI scan, so it's not suitable for V-plasty. One of the options that can be done is what is a mini open decompression with V-plasty, which is like an open V-plasty. And while you're doing that, you go in and decompress so you don't have that fragment coming out. So this is pretty much what is done. You do a laminotomy either on one side or bilaterally. You go around the cord, transfacetal or transpedicle, and take down that middle column. So let the neural elements open up, and then you put cement under vision. The question that people always ask is that when you do this, if the posterior wall is opened, what's going to happen? So the trick is to put in the needle deeper, to put in cement when it's more viscous, less liquid, and then to have a piece of gel foam between the cord, like down here between the cord and the cord posterior open cortex. And then under vision, if something comes out with a pen field, you can just pull it out because it doesn't heat up like an atom bomb. It's just, if it's there, it starts to solidify, it heats up. So we keep putting in, cold saline, and then we keep taking out that cement. It works well. And then you want to just add an MIS fix if you think it's a thoracolumbar spine. If it's a mid-thoracic spine, sometimes you can get away. If it's a thoracolumbar spine, you may want to add an MIS fix. But this is a very rare scenario, and you do it only in very specific conditions. If you try to overdo it, you may have problems. So the indication is very, very specific when there's cord compression but no neurology. And that's when you would want to do it. Another scenario is when there's neurology. Now, this makes it easier in a way of homing in on the fact that you need an intervention. Now, when you have a neurology and a burst fracture or a compression fracture, you would grossly divide these injuries into intervertebral instabilities and intravertebral instabilities, which means that if the vertebral body is unstable with a cleft within itself, which is a more common scenario in osteoporotic vertebral fracture non-unions, you have one strategy, and if it's a disc vertebral instability, you have another strategy. So if it is indeed a defect within the bone, the option would be to fill the cavity or to close the cavity. So you have to decompress, because we are talking of vertebral fractures with neurology, but stability can be gained by filling or closing the cavity. So let's look at more details. So if you have an osteoporotic fracture with neurology and an intravertebral instability with no kyphosis, and you want to really save levels, typically in the lumbar spine, then you want to do this procedure. For example, this lady with a lumbar canal stenosis, which was well compensated for many years, had a domestic fall, and after that she couldn't get up. Every time she got up, she would buckle. So again, this was a dynamic instability, a dynamic compression. So merely taking down the laminae and opening up the roots was not going to anymore suffice, and you would have to stabilize. Now, being the lumbar spine, you can't stabilize the whole house. So you want to limit your stabilization. Your decompression has to be specific. So this is a good procedure here, where kyphosis is not an issue. So you just maintain a one level fixation. You may even put an index screw if you think so, and decompress well. So it's like a laminectomy fixation with cemented screws and cement plastic. So they do well. However, if there's a kyphosis, and this typically happens in the thoracic or thoracolumbar spine, you can no longer fix it in that manner, and you may want to use the kyphosis to correct. You may want to use this non-union to correct the kyphosis, and classic pedicle subtraction osteotomy as seen here then becomes your go-to. Of course, in this particular case, you could have just fixed it in situ with cement and decompression. But being a thoracolumbar junction, we preferred to actually close it down and fix it slightly longer, 2+2, and get a PA. So here you have a bone on bone. So the anterior column kind of reconstructs itself. Remember, these are octogenarians who are not that high demand. So as long as you take care of their of their stability, we are fine. Now, this scenario, intervertebral instability, is very, very rare in osteoporotic vertebral fractures, but I am going to show you a few cases. This more commonly happens in old healed tuberculosis or infections, and you rarely have these end plates going bad. And here you need to reconstruct the anterior column, because there's no anterior defect that can be closed, because it's a mixed bag of disc and bone. So, for example, this one, I don't know what your thoughts are. Any thought for anterior surgery here, Bala? What's your threshold to do anterior, like a anterior approach for osteoporotic fractures?
No, I think I wouldn't do a standalone anterior procedure.
Calcified aorta, and you're going
Yeah,
to have a tough
yeah.
time
So
retracting.
these are highly morbid procedures, especially hypertension, post-angioplasty on anticoagulants, diabetic. So no, I think, as much as possible from the posterior, all posterior approach, anterior, fill in with bone or whatever needs to be done. I would all go from the posterior to the anterior.
Loud and clear. Stay behind and stay long. Like, don't think of short fixations. Don't think of going anteriorly, because you'll have a hell of a time. And because there's more calcium in this aorta than in the bone, you can see. So retraction of any of the vessels can cause a big problem. They're quite fragile, and more so, once you fill the defect in the front, your fixation in the front is going to be pathetic. Cancellous screws. They have no use. Like, you got to do the fixation at the back. You got to go long. But because this kind of a defect, as you see in the picture on your left, cannot be filled in or closed, you need to reconstruct it from end plate to end plate. Otherwise, you're going to have a failure for sure, because your screws themselves are on thin water. I mean, thin ice, because the bone is very, very fragile. So you got to be able to, go to this middle column through the back. And the best place to learn this is when you do your T-lifts. When you do regular T-lifts for the degenerative spine, you're going through the facet, and it's a don't think about it, but really, if you do a T-lift in the thoracic spine, that's your game. You're getting into the middle column from the back and pushing in an implant from bone to bone. So it's really not as hard as you may think, the procedure to do this surgery. And in the thoracic spine, you can even sacrifice roots. In the lumbar spine, you want to use a thinner cage which you thread through the roots. You undersize your cage and then collapse the spine on top of the cage. So you shorten a bit, but you still maintain a lot of length by reconstructing the anterior column. So here's another case, again, not so common, but you see them time to time where after a domestic fall, there's a disc vertebral instability. Now, guess what was done here? Dr. Soma, are you comfortable with this operation? Like, could you give our viewers, your critique on this surgery?
Yes, sir. Always going for the three-column fixation is better, especially in an osteoporotic scenario. Uh, but
I mean,
I don't
here
know
the
why.
certain thinking was that he'll get an extracortical hold with sublaminar wires because that's what we all advertise. But in the lumbar spine, it's a fail, isn't it? There's no rotational control. The wires
Exactly,
just got to
exactly.
pull out strength. And look where he's finished his fixation. It's on the top of a listhesis. So this is a recipe for disaster. And there's a ball of cement floating on the top. And you have a wire that's gone through the fractured bone also. You have a one wire above and three wires below. So this tacky fixation, as you rightly said, is not going to do its job, and sure enough it begins to fail, and this patient comes with progressive instability, and it's a disaster. She's now wheelchair bound, literally. Another one. So basically, if this person was given a better operation, you can't even imagine what I did here. I conserved her. I just said that, I don't want to touch her because she was very morbid, like multiple comorbidities. She was alive and she was kicking, and she said, I don't mind sitting on the. So basically, 1 year of teriparatide, the full anterior column solidified, and she lived happily ever after with that tacky implant at the back. Because all she needed was to walk around in the house, and she got what she wanted. She did not want a second surgery. The second surgery would have been an ilium to thorax fixation because you would have had to go down into the ilium. You have to cover for that spondy, take away the implants. You can't stop in the thoracolumbar junction, neither mid-thoracic. She's kyphosing. You'll have to go to T4. So it's like a German surgery, T4 to ileum in this highly morbid person. So here, teriparatide saved the day. Here's another case. This is my case where I thought I got a three-column fixation, but clearly I've gone short for a thoracolumbar fracture. It's a junctional fracture. We've not got his biomechanics that good, and I suspect our screws were not completely in place. I think they must have been slightly lateral, and you can see that over time it just pulls out. You still try to conserve them because you don't want to go back in. And this guy was a smoker, avid smoker, so he was like kept smoking after surgery until that lower screw started hitting his nerve root, and he started getting L3 radiculopathy. And then we could no longer conserve him or give him a brace because he came, howling with pain. So then we had to go back and do this. Now, this is a legit operation, according to me. I would love to hear your critique, but a thoracolumbar junction can be beautifully fixed with sublaminar wires because you go really long, and you don't worry about the levels. And here the wires actually got an extracortical hold, so the pull-out strength is good. It allows for some controlled collapse. So what happened in the screws will not happen with this wire. It's like a fireman gliding down his down the tube, and it allows for that anterior collapse. It's like almost like a dynamic fixation. This is a 6 stainless steel double molded rod, so it never breaks. So you're kind of reassured with this. So we've been using this as a bailout for a lot of these failed fractures in in osteoporosis. So I'm going to say that my take home message is that there are factors when you want to think ahead of vertebroplasty. You don't want to do vertebroplasty in these scenarios, and we spoke about them. And when you indeed need to do surgery, the standard of care would be to follow an algorithm where you consider doing a vertebroplasty versus a mini open vertebroplasty. And if there is neurology, then you want to consider the difference between an inter and intravertebral instability, and then decide between anterior column reconstruction versus a PSO or filling up the anterior column. So I'll stop there, and I've done my time, but I'm happy to have any discussion on this or any critique on the on the strategies that we discussed.
No, I think that was a fantastic and very simplified version of a complex problem. Though most of us think that, vertebroplasty, we just, put cement and, get away with it. And yes, most times you get away. And I say 80 to 90% times you get away. But you need to be prepared to manage the complications as a result of this. Soma, any questions first we'll take from anybody there? Or I've got a few questions.
Yes, sir. So one is what is your opinion on one kyphoplasty, sir? Second, Recently, there are like inflatable titanium balloons, kyphoplasty, retaining the balloon inside, containing the cement, and these kind of techniques, especially with that the one of the novel technique which you had introduced, taking away the posterior cortex which was impinging on the nerve root, and injecting a cement with the guide of gel foam which is protecting the cord. In these scenarios, do you think that a contained titanium balloon with cementing?
Yeah, so I think we are discussing two different procedures. One is a kyphoplasty, and I have my very solid reservations about kyphoplasty. I put it in the same category as a expensive vertebroplasty because what a kyphoplasty does is, I mean, we know, but for the benefit of the viewers, you put in a balloon with a very high pressure, and that tends to supposed to jack up the bone, so you retain height, and then you put in cement, so you're supposed to have a better kyphotic correction, which was proven to not happen. But because the industry was doing well, the implant industry, they wanted to still sell this balloon. So then they did some studies showing that the cement injected, once you've created a space, goes in much more smoothly and you have less chances of cement leakage and embolism. And that's right now the claim to fame for kyphoplasty. The fact of the matter is that all the studies that have shown this, much fewer, they're lopsided, much fewer numbers for kyphoplasty to V-plasty. So I think I rest my case there. So personally, I'm not a fan of kyphoplasty. I've done a few, but that's just for shine. I don't think there is a real game there. But the other thing you mentioned, which are expandable. So there are these, cement, I mean, the titanium blocks that actually deploy like a butterfly opening its wings inside the bone, and they lock into the bone, and then the cement locks onto them. So they seem quite exciting because we've all been doing, cage insertions in the bone, and that gives a very strong kind of a reconstructive hold. So I think that's a great I don't know, cage plasty, I think it's called, isn't it?
Yeah.
Stentoplasty.
Stentoplasty.
I think I don't know. I don't have a lot of experience. I don't know if you guys have any.
Yeah,
It seems like a
so-
good plan. Yeah.
So actually, the stentoplasty, it was available, I would say, 15 years ago. So these were called B twin cages, and you can put in them on both sides, and you can just jack it up, and it opens up. But it was not popular then. It had died down, and again, it is becoming a little bit more popular. So I agree with you. The same kyphoplasty, these guys in our team will agree that we do very less kyphoplasty because and it's double the cost or three times the cost. Though they think it's fancy to put a balloon inside, it really makes no big difference. But the stentoplasty, again, the same problem, because all you're doing is it is not exactly like putting in a cage, because the cage rests on your end plate, whereas this cage is still within your vertebral body. So it's just a nice big ball of cement which is just contained within metal. So I don't know, and I'm not aware of literature that really has more benefit than just doing a simple vertebroplasty. So
And what about Peter Paul Vargas? He's presented from the Hungarian surgeon, discoplasty. And, I met a few Turkish surgeons last week, and even they've been doing like of course, not in OVCF. This is slightly digressing. But if you have a very frail elderly person who has a degenerative spine with instability, who needs a multi-level reconstruction, instead of doing an OLIF and a back and front and all that, Peter Paul Vargas just, and he's a very experienced and a very senior surgeon, well reputed. He's got published 4,000 cases of dysplasia. Just injecting cement in the disc and doing a fixation at the back. Any of you have had because he's got like 4 and 5 follow-ups, and he says that they don't outlive the reconstruction. Like mostly is done for these late octogenarians who have these frail spines. Anyway, that's one more addition to this discussion.
Sure. Just a couple of things. As you said, CT scan, we don't do that routinely. In your practice, would you do it as a standard of care before putting in cement?
Before any intervention, yes. If I'm doing an intervention, either cement or surgery, I do an MRI with limited CT cuts of the fractured area. Because sometimes I found, so there was this husband-wife, both of them, they came 2 years of each other. Both came in as OVCF, domestic fall, vertebral wedge compression fracture. But both of them had posterior elements broken. And if I'd subjected them to what I would subject an OVCF to, which is a low dynamic, low impact fracture, I would have created a problem. And all of them both these guys needed a posterior reconstruction of a big magnitude. So yes, I do in my practice because I want to be safe, but I think that you should do it. Yeah.
Yeah, no, I think that's a very important takeaway today because we have been caught out on one or two occasions where you're missing like a dish kind of a picture where you have, this and you think it's a simple osteoporotic fracture, but actually it's a little bit more biomechanically.
Lance fracture. Yeah.
You
Good
just
call.
miss out. Anything else, Soma, there?
Um, yes, sir.
In-
So, talking about osteoporotic fractures and these things, sir. So, if I may, what is your protocol? You might have an algorithm, no, sir, like for the DEXA score. What anti-osteoporotic medicines you start? Teriparatide or denosumab or romazozumab or a combination of both. Uh,
I think the
is there
first thing I
any
want to say
protocol?
is that we as spine surgeons or orthopedic surgeons should rest the initiative of starting anti-osteoporotic therapy because our endocrine colleagues are extremely tardy. They're extremely slow on the move and they are, treating paper reports. They're not treating the patient. That's my experience, at least in my city. So I take the initiative of starting treatment. And for that, you need to be well educated about all the drugs available. You need to be the torchbearer and you need to be the guy explaining, what drugs are where. So in my opinion, there are just two categories. One is save you from worsening, and one is drugs that actually create new bone. So we have romosozumab and we have teriparatide, which improves your bone mineral density. And you have denosumab and you have alendronate bisphosphonates, which retain your, stop loss. So any person who comes with an OVCF, an osteoporotic vertebral fracture, regardless of his bone density test, regardless of the DEXA scores, for me becomes a candidate for the top two drugs, like an anabolic, like bone forming drugs, because it immediately gets categorized as severe osteoporosis. Also, as also orthopedic surgeons or neurosurgeons, as surgeons, we like to look at numbers. So we always say this guy is a -3 DEXA. But really speaking, FRAX criteria given by the WHO, there are 10 criteria, of which only one is the DEXA. And we hang our hat on the DEXA and happily say that, okay, this is -2, so I'll give him this. But that's really far from the truth. And we should know better. We need to zoom out, look at the big picture, see if she's frail, see if she's had a, say, metatarsal fracture in the recent past, see if she's had weight loss, if she's kyphosing, lost body weight, strong family history of osteoporotic fractures, someone on steroids or anti-epileptics, all that put together, you actually scale this person and decide how osteoporotic this person is and decide what you want to give. Across the world, in the World Osteoporosis Forum, I think Dr. Bala is a part of it. The most, people are aggressive and they want to start with anabolics and then, pull on with the denosumabs to retain the effect of the anabolic. So all the OVCFs, I would start with teriparatide or nowadays Evenity also, romosozumab, and then after the loading dose, then continue them on denosumab.
Just a last question, if there isn't anything, Soma, is about the kyphotic fractures, which kyphos, after 6 weeks or 8 weeks. How aggressive are you with correcting the kyphosis?
I
Or
believe that we
sometimes,
need to correct because if you don't correct it, you're going to get the implant is going to be under tension loading and it's going to fall over. So I try very hard to correct. The good news is that it's very easy to correct them because the PSO in an osteoporotic fracture is like a PSO in an active infection. Just scrape out the bone and you crush it down and you're normally sorted. But like in the case you saw, you sometimes get caught out because you think you've done a PSO. In reality, you've not really realigned. And if you don't have, so you want to put zigzag screws, stagger your screws, put them into the cortex, sometimes into the end plate. You want to have one screw significantly medial. You sometimes put cortical trajectory screws. Sometimes you add a wire or a hook on it and really have a strong posterior implant. But to answer your question, I'm aggressive to correct mainly for biomechanical failure.
yeah, because most people, when we used to train, probably maybe neurosurgical way of doing it is to try to maintain, not overcorrect it, not try to correct it, because, and they say you just put adequate, well up, three down, but try to leave as it is and correct it. But I agree with you. More and more, I see that correcting them, they align properly and it stays longer. Keerthi, you have anything to ask?
Keerthi.
You're
So
on mute.
you're on mute, so.
Sorry, sir. Hi, sir. Keerthivasan here, sir. Sir, is there any way to decide on whether to go posterior like PSO or anterior reconstruction?
So you look at containment of the fracture. Like if the fracture is contained within bone, a PSO is adequate because then you're getting a bone-on-bone construct in the front, which is more, more stable construct. If the fracture is near the end plate, then no matter what you do, the bone is not going to heal with the disc, and you're going to be left with a unstable segment, a disc vertebral instability. That's where you would want to reconstruct. And sometimes it's a very subtle problem. You just do like a T-lift cage. Sometimes it's like in some of the cases that I showed, the bone is completely melted away, and you need to take away a chunk of bone. You need to take two discs out and do a formal reconstruction. So you need a very nice costotransversectomy or a wide lateral approach. And unfortunately, you need to do this because if you don't, it's going to fail. And most of these guys don't give you a second chance in terms of their morbidity. Like you want to just take care of them the first time. But as we discussed, going anterior, I'm very much against. Like everything can be done at the back, even if it takes longer. But I would almost never go anterior in an older person.
Thank you. Thank you so much, Abhay. It's fantastic to have you. We'll miss you in the actual conference, and that's why we made it a point to get you here. So you're a
Pleasure. Thanks for having me and making me a
here.
part of your crew.
We actually have an entire session on osteoporosis. We have about 8 talks, addressing various issues to similar to what we have, each one separately. And AO Spine has also volunteered to give a few talks in that specific topic. And there's also a session run by AO Spine, which is also related to osteoporosis. So, which means that there's so much importance because we're seeing more and more elderly people, and you're going to see a lot of osteoporotic fractures. We are going to be seeing a lot of them. So thank you so much for giving us an enlightened talk, I would say. Enjoy the rest of your evening. Thank you so much. Thank you. Bye-bye.
Thank you, sir.
Thank you.
Thank you.
Bye.